See.
You're welcome.
Yeah, can
Thank you.
you?
You can. Yes, I can hear you very well.
Oh, okay.
Check your screen and other things. Once it's able to start, wait.
Oh, okay.
Yes. You're welcome.
So let me try and share my screen. See.
Yes.
Àjí ìbò ni ọ̀rẹ́.
How far you know?
Longest time.
Ah, Tokwe.
Kí ló ṣẹlẹ̀?
Good to see you, my brother.
Same here, bro. Same here. I log in earlier. I don't want to miss am.
Oh, great, great. Busi, can you see my screen?
Yes. Very well.
Oh, okay, okay. Okay, so.
Can you put it in slide screen? Yes.
Oh,
That's
okay.
true. Slide show. Yes, that's true. So we'll start very soon.
All right, no wala. Let's wait till 8 then.
Yes.
Yeah.
Good evening,
Doctor,
Doctor.
you're welcome.
Yes, good evening.
Moderator. So
Oh,
once it's 8, yes, we will start.
okay. Good evening, everyone. I believe we are glad to be on this call. It's just some minutes before 8 o'clock, and I would want us to do the opening prayer at this time so that by 8 o'clock we can commence the program proper. So please, Mrs. Mommy Bolajoko George, please, ma, could you help us with the opening prayer, ma? Mommy Bolajoko George, please, could you help us with the opening prayer?
Let us pray. In Jesus' name,
Amen.
everlasting King of glory, we thank you. Blessed Redeemer, we give you all our praise. Our Father and our God, we commit the lecture into your able hands this night, that Lord, you give us the grace to be able to know and acquire more knowledge on what to know about hypertension in the mighty name of Jesus. We commit the lecturer into your able hands, that everything is going to teach us today, we shall put it to use in the mighty name of Jesus. For in Jesus we have prayed.
Amen.
Amen. Amen.
Thank you, man.
Thank you very much, ma, for taking the opening prayer. At this point, I want to welcome every one of us to today's Zoom meeting. My name is Dr. Aremunyoluwa David, and I'll be moderating today's program. I'm a senior registrar in the Department of Family Medicine, Lagos State University Teaching Hospital, and I'm glad to be on this call. Thank you, Dr. Oladunjoye, for the special invitation extended to me to moderate today's program. And as we all know, we are on to the Hypertension Awareness Forum, which is a forum that hopes to shed more light on what hypertension is and things we can do to prevent and manage hypertension. The convener of this Zoom meeting, who is the head of the Hypertension Awareness Forum, is Dr. Oluwabusi Oladunjoye, and he has been a brother, a friend, and a colleague to me. So this evening we'll be learning about hypertension in the young, and I can tell you that it is a very important topic we should learn, especially knowing that the age group in which hypertension arises is coming down. In the past, we used to attach hypertension to those in the older age group. But unfortunately, now in our world, we have people younger than 30 having hypertension. So today, we have a learned scholar amidst us who will do justice to the topic. It will do justice to the topic so that we'll learn more about what the topic is. At this point, I would want to introduce our speaker, Dr. A.O. Hajibari. I'll be reading an abridged CV of Dr. Adiola Olubumi Ajibari. Dr. A.O. Ajibari is a consultant physician and cardiologist at Lagos State University Teaching Hospital, Ikeja, and also a senior lecturer at the Lagos State University College of Medicine, Ikeja, Lagos. He is a 2005 graduate of the prestigious Obafemi Awolowo University, Ile-Ife, where he graduated in the top 5% of his class and later obtained the fellowship of the National Postgraduate Medical College of Nigeria in Internal Medicine and Cardiology subspecialty in 2015. He has attended many leadership trainings and symposiums and symposia, and obtained several certifications, including the leadership certificate from the University of Washington, United States. He is a prolific writer, public speaker, and seasoned academic who has published over 50 papers in local and international peer-reviewed journals. He has attended several conferences and symposia, both locally and internationally, where he has presented his scientific and academic works. Dr. Ajibare is happily married with children. At this time, I want to call on our speaker, Dr. Ajibare, to do justice to the topic. You are welcome, sir.
Thank you, Dr. Aremu, for the kind words. I really appreciate it. Yeah. Firstly, I want to appreciate Siola, the winner of the hypertension. Those that know myself and Busuyo, we've been together for a very long time. We're classmates in the medical school. So, of course, anytime it comes to me about this hypertension awareness forum thing, please there to support. I'm here once again. That was the second one. I think there's the sixth one, so I'm happy to be back again. So the other time I spoke about hypertension and the heart, and this is a more difficult topic to speak to. And the reason why I said so is because this is a specific topic, but I'm speaking to audience that cut across medical and non-medical line. And even on the call, I can see that we are cardiologists, there are, even physicians of diverse practice, ranging from clinical practice to non-clinical practice. And my job today is not only to speak to the topic of hypertension, it's also to find a balance that everybody on this call, regardless of your academic background, will be able to take home something, as much as possible.
Has everybody completed the form and submitted?
Please, sir, can we all mute ourselves?
We all do that. Simone, did you complete it? Yeah.
Okay. So I was speaking on the topic. Please, can we mute ourselves, please, so that we don't distract each other? So we'll be speaking about hypertension in the young, and I've been introduced earlier. My name is Jibari. I will be doing it on these. Sorry, please let me try and be muting people that are interrupting our discussion.
Yes, sir. I'll be doing that, sir.
Oh, okay, that's fine. That's fine. Okay, so we'll be discussing our topic under this outline. We'll give an introduction, give definition, talk about classification, hypertension, different classification, we'll cool down to investigation and treatment. There's this definition that has stood the test of time when it comes to hypertension. The values change, but this definition has changed since 1971. That was given by M. and Rose. And the definition of hypertension is that blood pressure level in which benefits of treating that blood pressure equivocally outweighs the risk of not treating. So different guidelines are proposed, different values. However, for the sake of this presentation, we are going to be talking about the values based on three parameters, which are the office blood pressure monitoring, home blood pressure monitoring, and ambulatory blood pressure monitoring. So I know that we have heterogeneity of audience, so I'll try and break it down as much as possible so that I'll take something. So when we talk about home blood pressure check, it is the blood pressure that you can do for yourself at home. You take the blood pressure machine, you check your blood pressure, and you find an average of that blood pressure. If that blood pressure is persistently above 135/85, the top value is the systolic blood pressure, the down value is the diastolic blood pressure. So if an average home blood pressure check that is above 135/85 persistently said to be hypertensive. Then when you come to the hospital and the doctor checks your blood pressure and the upper reading is equal to or exceeds 140 millimeters of mercury, and the downward one, which is the diastolic blood pressure, exceeds 90 millimeters of mercury, said that you are hypertensive. When the third parameter is the ambulatory blood pressure monitoring that we use sometimes in our practice in the hospital or in diagnostic centers around, that will put the blood pressure monitoring on you all through a 24-hour period. And we now find the daily average. If the daily average is greater than or equal to 130/80, said that you are hypertensive. That is the definition of hypertension. And we all know that the prevalence of hypertension is increasing worldwide. And it's even said that a quarter of the world population is hypertensive. And hypertension remains the leading modifiable risk factor for cardiovascular disease and death worldwide. So how do we classify hypertension? There are different ways of classifying hypertension, but I want to, tease it until we get to where we are going. Then we can now pull down on hypertension. According to severity, the blood pressure is classified into normal pre-hypertension stage 1, stage 2. That's the Joint National Committee of Hypertension Detection, Evaluation, and Treatment of Hypertension classification. Although there are still other classifications, there's the European Society of Cardiology classification and all that. For simplicity, I picked this one so that we know that normal blood pressure, systolic and diastolic, are less than 120/80 respectively. If your blood pressure is more than 140/90, you are hypertensive. In between the normal and the hypertension stage, stage that we call pre-hypertension, which now need to intensify lifestyle changes. And in some rare cases, you even need to institute BP at this point in time. So that's talking about classification severity. So we can also classify hypertension based on etiology, in which we classify into essential hypertension or primary hypertension and secondary hypertension. Secondary hypertension means that these hypertension have an identifiable cause. And it said that 5 to 15% of all hypertension cases are secondary, while essential hypertension have no identifiable cause, but they have risk factors, some of which we'll still talk about in the course of this presentation. They're now coming gradually to where we are going to start our presentation from today, is classification according to age. So this can be classified into hypertension in children and adolescents, then hypertension in the transition period between children or adolescents and adulthood. This is the period where they now change their doctors from pediatricians to adult physicians and all that. Then, of course, hypertension in young adults, which is what we are talking about today. And I know that on this forum, we have previously discussed hypertension in older persons. So I'm now going to transit into the presentation of today. However, when we want to talk about the young, we need to define our age appropriately, so that we're not going to do like some political parties in which they are youth leader 65 or 70 years. We need to clearly define what a young person is. So there are different guidelines with different age, cutoff for young. NICE guidelines, the American guidelines, European guidelines. But for the purpose of this, my presentation, I will be adopting the European Society of Cardiology and the European Society of Hypertension guideline, which adopts 40 as the cutoff for young age. So now we are where we are supposed to be and to talk about hypertension. So proud to now, hypertension has been said to be very uncommon in young population, and that most of the hypertension cases that you see in the are secondary hypertension, meaning that it is hypertension that have an identifiable cause, whether it's chronic kidney disease, whether it's endocrine condition and all that. However, recent studies have now shown that younger people are beginning to have hypertension, and many of this hypertension is no longer secondary, it's essential hypertension. And some studies have said that about 1 in 8 adults aged between 20 and 40 years are hypertensive. So there's a worldwide estimate on the prevalence of hypertension, prevalence of hypertension in young people at around 13% for males and at around 7.4% in women. And as they are now getting older, the prevalence is increasing. I mean, so that I will break it down, at least for many of us that we are not medics. So what it means is that in people, the prevalence as a year 2000 in people between 20 and 29 years is about 10 people out of 100 people having hypertension. And as they now get older, to between the age of 30 to 39, we are now seeing between 12 to 18 persons among 100. However, the prevalence in the United States of America puts it at about 7.8% between the people between the age of 18 and 39. So there was a study that was called the Strong Heart Study, in which about 2,000 Native Americans aged between 14 and 39 were studied. And it was found that those with pre-hypertension, that's just like I said earlier, blood pressure, systolic blood pressure between 120 and 139, and diastolic blood pressure between 80 and 89. And those that are hypertensive have a higher prevalence of left ventricular hypertrophy than normal people. So, and what do I mean by left ventricular hypertrophy? It means that the heart is getting big. So, meaning that those that are pre-hypertensive or hypertensive have a high prevalence of big heart compared to non-hypertensive people, which can now, become a problem later in life. So we did an opportunistic study during the May measurement month of 2021 in Lagos, Nigeria, in which we looked at cardiovascular risk factors among, adult male socialites in Lagos. So what did we do? We looked at them, we did their blood pressure, we checked their lipids, we looked at whether they are obese or not, and looked at different cardiovascular risk factors in them. We now partitioned it into age group. So for the purpose of this presentation, let me just limit it to hypertension. So this study was published in the Journal of Epidemiological Society of Nigeria. And we found out that people between the age of 31 and 40, we had a prevalence of up to 41.9% of hypertension in them. And this increased as the age moved forward. Between 41 and 50 went to as high as 56.7%. And of course, people greater than 70 years had a prevalence of 87.5%. So this is just to tell us that hypertension is no longer a business of the older people, and young people are also having hypertension. So why should we emphasize hypertension in young people? And it's because of that erroneous belief in the past that people that are young don't have hypertension. So this now makes them to have very low awareness of blood pressure. They have a slower rate of diagnosis. They have poorer blood pressure control than older people. This is alarming. And that is why we need to emphasize talking about hypertension. And of course, although we're having, a higher prevalence of primary or essential hypertension in them, however, in this group of people, there are still some, level of secondary hypertension, which are treatable. So instead of people to now be on lifelong antihypertensive therapy, if we identify a secondary cause, we can go ahead and treat those ones that are treatable so that they are not condemned to a lifetime of taking hypertension medications. And of course, hypertension in the young is associated with more heart and brain abnormalities, and this is likely going to cause more problems as they are getting older. And young people usually present with extensive hypertension-mediated organ damage. So for the sake of the people that are not medical, what it means is that if you have been hypertensive for a while and you are not taking care of it, it can cause some problems in the like, causing visual problems. Patient can have intensive retinopathy. They can have big heart. They can have heart attack. Heart can fail. They can have kidney problems, and so on and so forth. Young patients that are hypertensive, I mean, if you don't treat it, it's going to lead into more elevated blood pressure in later life and it will cause problems. So people with systolic blood pressure that are high at a younger age have more tendency to have higher coronary artery calcium score later in life, which can now translate to heart attack later in life. And of course, there's, just like I said, there is an increase in prevalence of essential hypertension in the lung, and it's rapidly catching up with secondary hypertension. And of course, all the risk factors of the elderly people are also applicable to the young people. And what are these risk factors? So you agree with me that there is higher prevalence of smoking and alcohol drinking among our youth of today. And many of them indulge in high caffeinated fizzy drinks, recreational drugs, sexual enhancement medications, and all that. And there's also an increase in obesity, overweight, high risk ratio, and many of them have family history of hypertension. And like we mentioned earlier, the risk of hypertension increases as they are getting older. Diets that is high in salt, diabetes mellitus, socioeconomic impacts, high cholesterol level. People are becoming more sedentary these days. Lack of exercise, poor nutrition, lack of education, history of family history of secondary hypertension, and so on and so forth. So these are some of the risk factors that we look at when we are looking at this young population. We can now put it together and arrive at a diagnosis. A long time ago, people walk around to get their food. But these days, you don't even have to lift a finger, or you just need to click, order whatever you want. So more sedentary people in the world is translated to more obese people in the world, and it's translating to more prevalence of hypertension. In those days, at least when we were growing up, you hardly find an obese child. But these days, it's now almost becoming like a norm. And you also agree with me that, something has to give. The television are not getting slimmer, then the humans should get slimmer. And if the humans are not getting slimmer, television and the phones are getting slimmer. So this is the reality of our present day world, that the people are getting more obese and the devices are getting slimmer. So what is secondary hypertension? I've been mentioning it all day. So just like I mentioned earlier, secondary hypertension is an hypertension that has a direct cause that is related to it. So meaning that if those causes are addressed, then the incidence of hypertension can be removed. However, for you to make a diagnosis of secondary hypertension, you need a high index of suspicion. And of course, by the time you make this diagnosis, many a times or sometimes, the diagnosis and the treatment will be curative, especially young patients. Like I mentioned earlier, depending on manuscript that you are looking at, some had put the prevalence at between 5 and 15%. However, some of the things that will make us to suspect secondary hypertension in people are that when you see, severe resistant hypertension, you have hypertension in very, very, very young people, or you have rapid onset of hypertension in somebody that previously he has been normotensive, he's had normal blood pressure, then all of a sudden the blood pressure now shot up. And when we see this kind of thing, guidelines have said that this is for the doctors once you are suspecting secondary hypertension or you make a diagnosis of secondary hypertension, it is best that you refer to experts for clinical management. So there are some of these things that we'll still talk about, different causes, there are renal causes, there are endocrine causes of hypertension. And one of the things that we also all have to talk about is the issue of obstructive sleep apnea that is now becoming more prevalent in our society as a result of obesity But it is not only obesity that causes, OSA, that's obstructive sleep apnea. So these people have to be referred for expert management once the diagnosis is suspected of. Then, yes, for the doctors on the call, by the time you institute an angiotensin converting enzymes in a patient that you are treating for blood pressure and the kidney function worsens, then you start suspecting that the patient may have renal artery stenosis, which is one second cause of hypertension. So what are the predictive factors for you to suspect secondary hypertension?
Oh, I can do that. I can do that too.
The predictive factors are that when you see severe hypertension in somebody less than 30 years, or you see any grade of hypertension in the child, then you are most likely thinking that this may be secondary. Then somebody that has been otherwise having normal blood pressure, then all of a sudden the blood pressure shot up into the sky, then suspecting secondary cause of hypertension. Or if somebody has resistant hypertension, I'll still discuss resistant hypertension in details. But when you have somebody taking 3 or more, medications with the diuretics inside as standard medication, and the blood pressure is still not bulging, then you think that the patient has resistant hypertension. You start looking for secondary causes of hypertension. If a patient comes to you with hypertensive emergency, it comes with encephalopathy, it comes with acute pulmonary edema, then you are thinking that the patients have secondary hypertension. Or you do an ambulatory blood pressure in a patient and it's not dipping. So for the purpose of people that are non-medics, what it means is that normally the normal reading of blood pressure is that as you wake up in the morning, the tattoos during the then at night it now comes down. So that's the normal dipping. Blood pressure is supposed to go down. You now see somebody that the blood pressure is not going down at night. Do an ABPM on the person, and the blood pressure is not dipping at night, then you should suspect secondary hypertension. A patient coming to you for the first time with blood pressure, you have seen extensive hypertension, has pronounced level of hypertrophy, do his urinalysis, you are seeing proteins, do his fundoscopy, you are seeing hypertensive retinopathy, should suspect secondary hypertension. Then the patient is coming to you are seeing obvious proptosis, are seeing features of endocrine causes of hypertension like thyrotoxicosis and all. Then should suspect, like I mentioned earlier, obstructive sleep apnea, and patients with symptoms of pheochromocytoma, I will still mention them, family history of pheochromocytoma, suspect secondary hypertension. Yes, we should talk about causes of secondary hypertension. Try as much as possible to break it down for the non-medics on the call. But if I can't, then make it up to you in some other areas. So secondary causes of hypertension can be genetic. That's the one that you inherited from your parents, or it may be acquired, the ones you pick up after you were born. The commonest of these, or the most important of these, are the monogenic hypertension syndromes. So monogenic in the sense that it's a single gene disorder, and it causes secondary hypertension even in children, adolescents, and young adults, and they are associated with either a suppressed plasma renin concentration, plasma renin activity, plasma aldosterone concentration, depending on the type. And for the sake of residents in internal medicine that are going for exams, or people that are writing for an exam, so it's very, very, very important. Because I remember in those days when we were doing residencies, training, these are some of the things that we had to know before we went for exams then. So Victor here is on the call. So remember, we used to have mnemonics for all this stuff so that we can shine brightly in exams when it comes. So the common ones among these, I'm not going to bore us with this, but it's just to know that they exist. And Liddle syndrome. I remember then what we used to code Liddle syndrome with is that everything in Liddle syndrome is little. So they have hypokalemia, low hydrogen ion concentration. So they have alkalosis. They have low plasma renin activity. plasma renin concentration, plasma aldosterone concentration, and all that. And the reason why these diagnoses of these disorders are essential is because they have specific drug treatment for them. Like for Liddle syndrome, treatment is either you give tramterine, give amiloride. Then, of course, others like Gordon syndrome, Gellar syndrome, glucocorticoid intermediate hypertension. Don't let me bore you with this. Just know that all these syndromes exist. And still for people that are going for exams, so their questions are going to come on low renin level with low aldosterone, so hyporeninemic, hypoaldosterone level syndromes, and others like that. So that is that's about monogenic hypertension syndrome. Then let's talk about other causes of secondary hypertension. Mention obstructive sleep apnea, in which we may have to do sleep studies for this patient to make our diagnosis. And the first thing that patient with OSA are going to explain to you is that, my partner says that I snore heavily at night. When I wake up, I'm not refreshed, I have headaches. And during the day, I have daytime somnolence. I get to work and I'm feeling sleepy all day. I cannot, So depending on the level, so we can do sleep studies for them, look at diagnosis and treat them appropriately. And of course, renal parenchyma disease, which will be given away by urine disease or abdominal ultrasound, do electrolyte urea creatinine. So there is something called fibromuscular dysplasia, in which the renal artery becomes thickened and narrow. So this will now cause hypertension, usually common. So the doctors on the platform will know that to make diagnosis of this, we may have to listen for renal breath and also to request for some investigations and diagnosis. So there's something also called primary aldosteronism and pheochromocytoma, which is episodic symptoms. You have paroxysmal hypertension, pounding headache, excessive sweating, palpitations, pallor, and blood pressure usually level. So for the non-medics on the call, what we are just trying to say is that if you are feeling something that is not usual in your body, it's time to see your doctor and let the doctor take it up from there, and we can make our diagnosis and treat you up. So Cushing syndrome is also a cause, is responsible for the sense of secondary hypertension. Thyroid diseases, a patient comes to you, he's tachycardic, he has heat intolerance, he has proptosis. You should request for a thyroid function test and make diagnosis of this secondary hypertension. Coarctation of the aorta is also there. It's rare, but it's present. And this can be, diagnosed by making, by checking blood pressure in both arms or checking, upper limb. When you now start seeing the blood pressure difference of systolic greater than 20 milliliters of mercury or diastolic greater than 10 milliliters of mercury. So this is also emphasizing the fact, so for both medics and non-medics on it, that it's important that we do blood pressure in both arms to know if there's going to be any difference. So now summarizing the incidence of secondary hypertension according to age, to say that in the age that I'm talking to, which is age of 18 to 40 years, the common cause are still renal parenchyma disease, which is kidney disease, endocrine causes, fibromuscular dysplasia, obstructive sleep apnea, genic disorders. So I think we'll just talk about some other causes, which would include medications. Some of these medications include oral contraceptive, because of course young people try to plan their family and all that. So oral contraceptive pills, not common, can cause mild to severe hypertension in some people. So when you have high blood pressure, it is advisable that you should use other family planning measures. So these days, everybody wants to be slim and all that. Sibutramine and phenylpropanolamine have been, identified as some medications that can increase blood pressure in patients. Nasal decongestion, stimulant medications, amphetamine, cocaine, ecstasy, energy drink, especially in our youths, mixing it with alcohol, have been shown to be some of the stimulants that can drive your blood pressure up. Then, of course, some of the medications that we prescribe in the hospital, for the sake of people that so it means that some of these medications, when you are taking them, the doctor will need to monitor your blood pressure more closely, and that many of these medications, even when they are for good use, like giving patients that are asthmatic steroids, also need to be monitoring their blood pressure because steroids itself, can increase blood pressure if taken for a long time. Then also, non-steroidal inflammatory drugs can increase blood pressure. It can cause renal damage, which will now in turn increase blood pressure, just like herbal remedies. So we just need to be careful about medications that we put in our mouth and avoid taking medications without prescription. So at this point, I think it will be good to talk about resistant hypertension. Though many studies have said that true resistant hypertension is rare. However, we'll still talk about resistant hypertension. I will now talk about pseudo-resistant ones later. So when you are, okay, so let me start from here for the sake of the non-medics of the call. So sometimes when you are hypertensive, many times we'll give you 2 or more medications to control your blood pressure. And when we now give you those medications, we need you to come back so that we start either titrate those medications up or titrate it down. Because many times some patients will tell me that I was only giving the medication for 1 month, and when the medication finished, I just went off the medications and not taking it anymore. Okay, so what we do is to give you those medications for a particular period of time, and we expect that you come back for re-evaluation. So when you come back for re-evaluation, we can titrate these medications. So when we are now titrating this medication, if we now get to that point that you are on 3 or more medications, one of it is diuretics, and we have maxed out all the medications to their maximum doses, and your blood pressure is still not controlled, then we say that your blood pressure is resistant, then we now do some other things to get it under control. However, like I said, studies have shown that true resistant hypertension is rare, although it's present, but there are some things that will make it look as if your blood pressure is resistant when they are actually not. So one of it is poor adherence to prescribed medication. Some patients will take medication, they will take it in the morning today, they will take it in the afternoon tomorrow, they will now take it in midnight the other day, or they now don't take it at all. And when the doctor now asks them, they say, yes, I'm taking it. So that is not resistant hypertension, it's due to none or poor adherence to medications. There's also something called white coat hypertension. When some people come to the hospital, based on, a whole lot of things that can happen, blood pressure just suddenly goes up. And when they are out of the hospital, blood pressure is controlled. So those kind of patients will tell them, do their blood pressure at home and bring the values to the hospital, put an ABPM on them so that we monitor it. So those ones they are pseudo-resistant. So sometimes there are some poor office, blood pressure measurement technique. I'll still show some pictures that would look as if the blood pressure is not controlled. For example, if you are using a cuff that is too small, make the blood pressure, exaggerated, but it's actually not. So when it's time for you to increase the dose of medications and you are not increasing it appropriately to meet the patient's demand, it may look as if the blood pressure is resistant when it's not. So when you gain too much weight or you take excessive alcohol, take salt in high quantity, look as if the blood pressure is resistant when it's not. Then, of course, substances, some of the ones I mentioned earlier, commonest one around it is sexual enhancement medication that many of them take, or alcohol, or energy drink, obstructive sleep apnea is there. If there is an undetected secondary form of hypertension and you're giving medications that will not sort it out, just like we said in Liddle syndrome, you are giving amlodipine, you are giving lisinopril, and you're not giving tranterine, so you can see this, resistant hypertension when it's not. And when somebody has chronic kidney disease and arteries are stiff, look at it. So these are some of poor techniques of checking blood pressure. Using blood pressure machine that is too small. Somebody is checking blood pressure, the hand is hanging on the floor, is talking, is cross-legged, checking blood pressure, and the person is wearing, is putting on a long sleeve shirt, and you are, checking the blood pressure on top of it. You are going to, wrong values. That will now take us to the proper condition of checking, which is as shown on the screen right now. So the arm should be well rested. You should use an appropriate cough. You should make sure that the patient are not eating or smoke, taking caffeine in the last 30 minutes. Patient is rested for at least 3 to 5 minutes. His back is well rested, the hand is well rested, using an appropriate cough. Take 3 values, you discard the first one, find an average between the second and the third. Those are proper ways in which you check blood pressure. So if you now do this, and the patient is on maximum dose of 3, more medications, one of it being diabetes, then you can now say that the patient has resistant hypertension. Then with the cardiologist will now take over from there. So I've mentioned oral contraceptive pills and hypertension. Yes. So it's advisable that if you're hypertensive, you use, other methods of family planning, other than oral contraceptive pills. So how do we investigate in young patients that come to the clinic with high blood pressure? So the 2 major things I want to do is I want to investigate to exclude secondary causes of hypertension. So if you don't find out that secondary cause, the treatment may not work. Then we want to find out if there's evidence that that is what many of these guidelines advocate, especially. Basic investigations, just like I said when we're talking about monogenic chronic kidney disease, many times your electrolyte urea and creatinine sort you out. So by the time you do your electrolyte urea and creatinine, you have seen, overt evidence of kidney damage then. It's most likely that it's hypertension that caused target organ damage, or it's the kidneys or chronic kidney disease that is driving the hypertension. It can also give you an insight to whether you are dealing with monogenic syndrome, other secondary causes of hypertension, like Cone syndrome, aldosteronism. So, of course, you want to check the urine and check whether the patient is spilling protein inside the urine. You want to do a chest X-ray to check the size of the heart to know whether the patient has left ventricular hypertrophy. So the same thing with with ECG and echocardiogram. The thyroid function test will help you to sort out, thyroid derangement. Serum cortisol assay will help you to sort out Cushing's, and adrenal vein sampling sort out primary aldosteronism. Of course, there are some people that pregnancy either cause their hypertension, or pregnancy will make it worse. So you need also to take a pregnancy test in young women that are coming with elevated blood pressure. Then you do renal scan to confirm your chronic kidney disease. Then you do all these other investigations depending what you are thinking about. And this is not to say that that every patient has to take all this investigation. It depends on the high index of suspicion of the doctor that will now determine, the investigations you are going to take. There's no point in doing a cardiac MRI, somebody that has chest X-ray. So you pick those investigations depending on what you are thinking. So how do we treat? If there is no secondary cause, if you have not identified any secondary cause, you treat them just like essential hypertension, like you treat. However, if you find a secondary cause, you have to treat according to what you have found. I will still mention, each category of secondary causes as we go on. So, of course, non-pharmacological treatments, pharmacological treatments, surgical treatment have been advocated because there are some surgically correctable hypertension, which we'll still talk about as well. So, non-pharmacological treatment. This was adapted from the Nigerian Hypertension Society 2020 guidelines. I mean, for some of us, for some people that don't know that, we also have guidelines in Nigeria that only import, the European Society of Cardiologists guideline or the American College of Cardiology guideline. We also have a guideline in Nigeria. And our guideline says that we should reduce salt intake, should do weight reduction, should improve physical activity, moderate the level of alcohol that you take, increase your dietary potassium intake, consumption of diets, increased, fresh fruits, vegetables, fruits in seasons, and you reduce your saturated fat. So this is the guideline for the management of hypertension in Nigeria as prescribed by the Nigerian Hypertension Society. So this is just a summary of lifestyle modification of managing hypertension. It's been said that a 10 kg loss of weight can reduce your systolic blood pressure as much as 20 millimeters of mercury. So if you do physical activities, you are exercising at least 30 minutes every day, most days of the week, blood pressure can come down as much as 9 millimeters of mercury. Then you should adopt the DASH eating plan. DASH meaning dietary approach to stopping hypertension, which you are consuming diet that is rich in fruit, vegetables, no dairy products. You reduce the content of your saturated and total fats, your blood pressure will come down. Then you moderate your alcohol intake, reduce your blood pressure. So this is for the doctors on the call. It's just to remind us on medications that we can combine and medications that we can combine. So out of the 5 classes of BP medications, we can combine most of them. However, you should remember that you should not combine angiotensin converting enzyme inhibitors and angiotensin receptor blockers because of dangerous hyperkalemia. So most of the time, we can do calcium channel blocker combined with thiazide or thiazide-like diuretics, combined with ACE inhibitors or switch ACE inhibitors for angiotensin receptor blockers. And for people with tachycardia or beta blockers, drug of choice. So I have to bring this recommendation, this guideline. Sometimes I see so many things that, different switch of medications and all that. The first thing that every doctor must have in mind is that when you see an hypertensive patient, your priority is to lower that blood pressure. That's the priority of the doctor. And when you are lowering that blood pressure, any of the antihypertensive agents would reduce your blood pressure. So you should prioritize blood pressure lowering. So it is not the time that you're now prescribing high-tech medication for somebody. So, and as bad as the economy is, I can still tell you that there are still some medications that are relatively cheap, still used to bring down. So we should prioritize BP lowering over any other hypertensive things that we want to do. This is not the time that you are switching a patient from telmisartan to irbesartan. Many of these medications have class benefits. So just put whatever the patient is taking and it's doing the blood pressure control, just keep the patient on it. So I've mentioned this, you can combine any of these classes. You should remember that ACE inhibitors and ARB should not be combined. And that many times when we are starting blood pressure control in hypertensive patients, should use combination therapy, at least 2 medications. However, in those scenarios where you are permitted to use just a single medication, if the blood pressure is just marginally elevated, or you have a patient that is pre-hypertensive or he has very high cardiovascular risk, and you want to bring in a medication, you can bring in very elderly patients that are frail. Those are the times that you can, do therapy. So now we'll now go to specific treatments. So if you now check your patient, he has secondary hypertension. So for example, like I mentioned earlier, see patient with needle syndrome, hypertension is driven by the epithelial sodium channel for activity. So the treatment is to use sodium channel inhibitory agents like amiloride or tartaric. So no matter any other antihypertensive you give them, you don't give them any of these two. That blood pressure is not. So a patient with congenital adrenal hyperplasia, so you can give them glucocorticoid supplementation and give them adaptone, that's mineralocorticoid receptor antagonist. So same thing for patients with syndrome of apparent corticoid excess. So give them mineralocorticoid receptor blockers. Patient with Jella syndrome, which most of the time is in pregnant women. So try and deliver the child as much as possible, and monitor them subsequently after childbirth. For Gordon syndrome, thiazide diuretic is okay for them. Familial hyperaldosteronism type 1, you give, glucocorticoid to reduce the corticoid antagonist excess. Then patients with familial hyperaldosteronism type 2 to 4, the treatment is surgical resection, but can give corticoid antagonist. Familial pheochromocytoma, medical management, then you can now do a surgical resection later. So what are these surgically correctable hypertension, aortic coarctation, how to fix the coarctation, pheochromocytoma, syndrome, same thing. Renal artery stenosis, you can put in a stent, obstructive apnea, weight reduction, other weight reduction surgery modalities can be put in place. Vascular hypertension, adult polycystic kidney disease, all these things can be sorted out surgery. In conclusion, I want to say that hypertension in the young is becoming more common, and that since hypertension is the commonest cause of preventable death, need to attack it holistically so that they won't come down with organ damage as much as possible. Etiology is still both essential and secondary, so we need to find out what the secondary etiology is and treat it as appropriate. Then we need a high index of suspicion, need to diagnose them early, need to refer them, especially to secondary hypertension, and early intervention so that we reduce the morbidities and mortalities associated with this condition. Finally, everybody should adopt healthy lifestyle, eat right, exercise right, and this should be started early in life in everybody. Thank you very much. I'll take questions and answers now.
Thank you very much, sir, for the presentation. I believe we had learned one or two things this evening. Thank you for taking it slowly so that everyone could follow, especially the non-medics. So at this point, without much ado, I want to ask, are there questions? Are there any clarifications? Or are there any general comments for the presenters? Please kindly make use of the electronic hand so that we can take such comments, questions, and clarifications. For those who prefer to chat in their questions, please kindly do so. Okay, while we are waiting for questions from the audience, thank you so much, sir, for the presentation. I want to ask, sir, is there from the list of different antihypertensives for young adults for people with hypertension in the young that is essential? Are there of the different classes of antihypertensives, is there a particular one that is preferred for the young adults? Is there, sometimes I see some people, they have bias for the ALBs, ACE inhibitors for the young, maybe because it has been linked to kidney cause has been the commonest secondary factor in them. So I wouldn't know, for people, for young adults with hypertension, is there any, with essential hypertension, is there any preferred medications of the antihypertensives for them? So that will be my own question, sir. While we wait for other questions.
Thank you very much. Okay, so while we're waiting for that question, because I will have preferred to take all the questions together. Since there's none,
people have like questions.
Okay, so since there is none for now, let me just take yours while we are waiting for others to ask their question. Okay, so like I said earlier, so two basic principles should drive everybody. Number one is that blood pressure should be brought down. Then number two is that you should individualize your patient's condition before you prescribe. So condition meaning that what are the things that you are saying when you are assessing them? Then number two, how deep is their pockets? However, if there's no barrier for all these ones, any of the antihypertensive drugs can, sort out the problem. So either ACE inhibitors, the guideline says that you can use ACE inhibitors, ARBs, calcium channel blockers, or the diuretics. Then, if you now have other compelling needs, so for example, now if a patient comes in with tachycardia, then now know that beta blocker should be part of the blood pressure medication that you're going to give them. So, or a patient comes in and he has thyrotoxicosis, know that propranolol will be one of the pillars of the medications that you are going to give. So I don't know if I've answered your question.
Thank you very much, sir. Thank you very much, sir. You have, sir. So please, I want to recognize the person with Talk by Leo to please make his comment, his or her comment at this time.
Thank you. So I'd like to ask Doc a couple of questions. So can hypertension or high blood pressure lead to an enlarged heart? I had an incident that hit close to me a couple of years back. He was very young, my youngest brother, in fact. Very fit, like me with the big tummy, he has a flat tummy. He plays soccer like 3 times a week. It's late and he didn't wake up, it was a huge blow. And they found out when he did the autopsy that he had an enlarged heart. It baffled everybody till now. I mean, someone that was that young, he was the late 30s, to be fit. We have no history of high blood pressure in both sides of my family. And then for him to have an enlarged heart and then for him to sleep and then wake up. So could this be a result of hypertension, or what could lead to this? And how do you mitigate it so that, it doesn't happen? How do you even prevent it or watch out for this?
Thank you, sir, for the question. The person with K. Adeshola, please, you are recognized, sir or ma'am.
Good evening. Can we hear me?
Yes, we can. Loud and clear, ma'am.
It's a man, not a woman. I'm Dr.
Okay.
K. Adikola. A very interesting discussion tonight. I want to congratulate Dr. Ajibari for this very beautiful and excellent which she has put together for all of us. I just want to know, I came in about 10-15 minutes into the lecture. I want to know how how common is it when you talk about essential hypertension and then the secondaries. And we know in adults, we talk about 95%. I don't know if it has changed now. It's just essential hypertension in most cases. These in the younger ones, how does the figure compare? That of the essential hypertension, those classified as essential, and those with known causes. Hello, I hope I was heard.
Sir, yes,
Yes, sir. Yes, sir. You heard loud and clear. Thank you for the question, sir. So I think in the absence of no other question, I've checked the. Okay, sir. There's another question on the chat group.
Okay, I think I'll just take it together. Yeah, I've sent those ones on the chats.
Okay, sir.
Yes, I think there are three of them. Ayo Maria was asking about sleep apnea. Oyike Chizuru was asking about safest BP medication in pregnancy. Then Peter Obi is asking about maximum combination. So those three have noted. So let me start answering from my very friend of many years, Tokwe Liu, and the question was about hypertension causing enlarged heart. So firstly, I want to say I'm very sorry about this. It's usually a big deal when somebody close to you. However, just like they say, every dead person is telling the living something. So, I mean, the message that is passing, even in death, is that we also need to be very careful. So, if a young person dies suddenly, an autopsy says that he has an enlarged heart, the first thing that will come to my mind is the cardiomyopathy, which is hypertrophic cardiomyopathy. And it's usually inherited and is a common cause of sudden cardiac death. And of course, it can happen in very fit, athletic people. And the problem is that they should not even be athletic if you have that kind of thing, because it's a common cause of sudden cardiac death during exercise. So the lesson that I would take from if autopsy show that he had an enlarged heart, then every family member has to be screened for enlarged heart. So, because that's the first thing that will come to my mind. Now, coming back to your question now is that, can hypertension cause enlarged heart? Yes, it's the commonest cause of enlarged heart. And this is how it works. The heart is a muscular organ. It pumps blood to all parts of the body. So if there's any resistance in the flow of blood to any part of the body, as a result of thickened arteries or stiff arteries, the heart wants to overcome that resistance by working harder. And it's just like somebody's like lifting heavy weight every day, the muscles will start developing. So the heart will now start getting big. So hypertension is a very, 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 very common cause of enlarged heart. So we have taken a topic in this hypertension awareness forum series where we talked about hypertension and the heart. And yes, that is the answer to your question. Beyond the question, I think every family member should have an echocardiography done, and let's see that there is no hypertrophic cardiomyopathy there in anybody. So that's that. Then the other one is sleep apnea. Yes, so obstructive sleep apnea, there are plenty places in Nigeria where we do sleep studies. That's in the pulmonologist do all kind of sleep studies to bring diagnoses that they will be able to address each and every one. And of course, it's one of the surgically correctable ones. Many things that we advise anybody with obstructive sleep apnea is to try and lose weight as much as possible, while also being aware that it can also happen with people that are not obese. So then the safest medication in hypertension. So the safe medications in pregnancy and hypertension, still calcium channel blocker, nifedipine in particular, alpha methyl dopa, hydralazine, and labetalol. Those are the safe medications that we give patients in pregnancy. Of course, the ACE inhibitors, the ARBs are not safe in pregnancy, so we don't even. So to stress it again, nifedipine, alpha methyl dopa. The maximum combination of antihypertensives that can be given. So you can give as many as possible. I was going to display a management plan of a patient, but I didn't see it, so that's why I didn't. So I have some patients, true resistant hypertension, down like 9 antihypertensive medication before we achieved, a control. So depending on what you are treating, you can just pick any of those combinations and, and treat it. So there's no maximum. But however, when we are talking about resistant hypertension, it means that the patient is on 3 or more antihypertensive medications as standard dose. And one of them has to be a diuretic before you say that the patient is resistant. But after resistance, then you can now start adding other medications. So you can do as much combination as possible. Don't pick same medication from the same class, and you also don't add. You don't combine ACE inhibitors with ARBs, just like I mentioned earlier. Yes, Dr. K. Adishola is one of my very fantastic guys. He's the president of Association of Private Medical Practitioners in Nigeria. So he's a big man. Yes, you asked a question on the prevalence of secondary hypertension. Yes, so depending on the literature, so it ranges between 5 to 15%. I even saw some studies that say that secondary hypertension can be as much as 50% depending on the age. However, in the very young people, children, secondary hypertension is as much as 90-something percent. Then in the older people, secondary hypertension can be as low as 5%. So as you are now moving across the terrain of age, so it now increases depending on the modality which the study is done and the age range that is affected. But generally speaking, secondary hypertension accounts for between 5 to 15% of all hypertension cases. So I think I've addressed all the questions that I have for now, except there are some that are just coming up.
Yes, sir. There are some new questions on the chat box, sir.
Okay, so let me. So I'll take it from. Okay, so there's a question on how often should young people check their blood pressure, except if there is no symptom. So I think I will just be reading it and answering the question. So GSO asks that GSO is one of my childhood friends. Went to school together as well. So you are welcome, sir. So he said, how often should young people check their blood pressure, especially when they have symptoms? So blood pressure it's not an invasive procedure. It's something that you can just walk in and do. And there's no side effect of checking blood pressure. So you can check it as often as possible. However, I think at this point, I just need to now chip in something that's beyond blood pressure check. But blood pressure is not the only number that we need to check. There are other things that we also need to check, like blood sugar, like your cholesterol, as you're getting older, prostate, and also and so on and so forth. So as you are getting older, we should at least between the ages of 20 and 40, we should do medical checkups at least once every 2 years. So between 40 and 50, you should do it at least once in a year, and above 50, you should do your medical checkup as often as possible. So that's beyond blood pressure. Okay, so do I ought to, friend, we've come a long time. I sometimes feel dizzy, and most times my blood pressure is 100/60. And the usual dizziness has made me addicted to energy drink to stay active. How do I manage this dizziness, which is my opinion is as a result of low blood pressure, to ensure the energy drink consumption negatively? Yes, so there is an entity called blood pressure. And okay, so before I even answer that question, I need to say that blood pressure is individualized. So I have some people that their blood pressure will be 80/40 something, and they will still be fine. However, if your blood pressure gets so low to the point that you are feeling dizzy, then we need to investigate what is driving that blood pressure down, because there may be some other things. So I think we still need to evaluate you to know what is driving that low blood pressure. However, if your blood pressure is low and it's not symptomatic, you don't need to do anything about it. just leave it the way it is, because I've had so many people say that somebody said I should go and drink Sprite, add salt in it, because that is your blood pressure. So imagine if somebody's steady state blood pressure 90/60. If that blood pressure goes to 135/85, start having features of hypertension, even though the blood pressure is normal, so to say. So your steady state, steady state blood pressure, just leave it if you have no symptoms. But if you're having symptoms of hypertension to your blood pressure of 100/60 to evaluate, also we still talk better after this presentation. So Tunji is also asking that can medications for other conditions, e.g. bad control pills, ADHD medication contribute? Yes, it's part of the things that we talked about. And we said that people with high blood pressure should try as much as possible to look for other methods of birth control beyond, oral contraceptive pills when they are. And we also mentioned so many medications that can contribute to increase blood pressure, ranging from steroids for asthma use, weight loss tablets, medications that we use to manage pains and all that. Yes, those medications can cause those. Then Peter Obi is also asking, please, in a situation where patient has a blood pressure of 170/60 plus cardiac arrhythmias, what's the drug of choice in it? So, arrhythmias can be bradyarrhythmia, it can be tachyarrhythmia, and the tachyarrhythmia may just be straightforward tachycardia, have premature ventricular contractions. So it depends on the type of arrhythmias. But if it's just straightforward tachyarrhythmias, beta blockers will be something that you can call in at this point in time. Dr. Usui, okay, yeah, he's talking generally about the hypertension and Dr. Usui, you are doing a fantastic job, and will always be there to partner with you anytime. This is something that is laudable, and we need to continue. So, Aziza AA is asking, what is the timeline to administer the various therapeutic doses to diagnose hypertension and resistance? So before you say before you say that hypertension is resistant, the patient is taking 3 or more BP medications at standard doses. And out of the 3 or more, there must be a diuretic there. So that means the patient is taking it at the same time. So, for example, now, it's taking maximum dose of amlodipine, 10 milligrams. It's taking maximum dose of telmisartan, 80 milligrams. It's taking maximum dose of dapamide, 2.5 milligrams. It's now taking maximum dose of, let's say, alpha-methyl dopa, and it's taking 1 gram TDS at the same time, and the blood pressure is not controlled. Then you can now say that, oh, okay, it is resistant. Then the first thing you now know how to look at is that, are there other causes of pseudo-resistance? Some of those ones that we talked about, not checking his blood pressure very well, he's taking his medication, haphazard, so when all those ones are removed, then you can say it's truly resistant, then you go to cardiologist. I sometimes feel dizzy, my blood pressure. Okay, yeah, I think I've sorted this. Okay, somebody's asking, yes, you need to see a cardiologist so that we can sort it out. So we need to know what is driving that blood pressure. So any comment on persistent diastolic hypertension, investigation and management? Yes, it's still the same thing. Need to investigate, know what is causing it, then and now address it. So then Professor Ademola Ileso, an old classmate also, is a professor of biochemistry, saying that we have remedies to manage hypertension. Okay, yeah, what of hypotension? Yeah, just like I mentioned earlier, hypotension is not hypertension, it's not causing symptoms. So I've seen, 2 questions, 100/60, and they are feeling dizzy. Even in the real sense of it, 100/60 in the real sense of blood pressure is still within normal range. Because systolic blood pressure is supposed to be between 90 and 139, and diastolic blood pressure should be between 60 and 89. So in the sense of blood pressure control range, they are within the normal range, but they are on the lower side of the ladder. So if they are having hypotension, then we need to know what is making them hypertensive. That blood pressure, then we can sort it out from there. I think I've answered all the questions in the chat box.
Thank you very much, Dr. Ajibare, for answering the questions. Thank you, everyone, for the questions asked. I guess it was my question that brought so many other questions, because initially it was looking as if there would be question. So as a parting shot, sir, please, sir, just a few comments on isolated systolic hypertension, and is there a preferred medication for such, sir? As the last question of the day, sir.
Okay. So I think questions usually bring out plenty comments. So let me start from. So there's something called isolated systolic hypertension, in which the top value as the systolic is high, while the diastolic is within. So in that kind of situation, calcium channel blockers and diuretics are good for those kind of blood pressure. Then at the same time too, now talk about people having isolated diastolic hypertension, because that also can happen. So meaning that the systolic would be in the normal range, while the diastolic would be elevated. So those ones, lifestyle changes, reduction in salt intake, exercise help to sort that one out. In addition to the blood pressure medications that you are taking. So it is not until both values enter greater than or equal to 140/80. If one of it, which is, the systolic can be isolatedly elevated, while the diastolic too can be isolatedly elevated. So at that point in time, if it's diastolic, we need to intensify, exercise, lifestyle changes, and all that, which cut across both groups anyway. Yeah, systolic, calcium channel, to sort it out. Thank you very much for that question.
Yeah. Thank you very much, sir, for the presentation. It has been a wonderful time this evening. I believe all the attendants, everyone that have attended can attest to the wonderful presentation, sir. Thank you very much. At this time, I want to beckon on the convener, Dr. Oladunjoye, to give his vote of thanks and make necessary announcements. You're welcome, Dr. Oladunjoye.
Sorry, before Busuye comes up. Okay, so I think Dr. Muyiwa Alonge is chairman of Ondo State Nigerian Medical Association. So he's asking, so maybe Busuye will answer. Can participants possibly have the recorded version, please? Busuye will need to answer that one. Then Noraz is asking that hypertension affecting the eyes. Is there any way we could reduce loss of follow-up, especially for young patients? Yes, this is part of the things that we are doing. This is part of the things that Dr. Busuye is doing. We need to engage people. We give people information, right information. I don't think people will be lost to follow. Everybody wants to live long. So let us continue to engage, our patients in our practice, so that we can keep our patients and make them to live longer. Thank you very much. Over to you, Busuye.
Thank you very much, Dr. Ajibare. Thank you very much, Dr. Aremu, for moderating. I want to also appreciate everyone that have joined, including our senior doctors and doctors and non-doctors on the group that joined the group. Thank you very much. I think this is one of the highest attended webinars we'll be having. I appreciate this turnout, and I want to, it's been well said this is our age group that we need to all focus on in Nigeria, because they are coming up and they are coming up with their own peculiar problem that everybody needs to rise up to attack to address. And one of the things that actually prompted to start this was that I realized that for diabetes, though we have the group of doctors for endocrinology and metabolic society, but we also have Diabetic Hypertension Association of Nigeria. I'm trying to find up till now. I've not seen Hypertension Association of Nigeria where they are non-doctors and they can now be able to mobilize one another, also be able to push for support, because there are things that are peculiar to hypertension. We talk of stroke, hypertension is a leading cause. We talk of renal failure, for which they will need dialysis, hypertension is a leading cause. Where are the people that pressure group to drive for support for these people? Where are the pressure group to be able to drive to support these people so that at least they can push for a lot of things? Doctors can put up guidelines, but there are things that can be done that pressure group can be able to work on. That's one of my motivating factor for starting this. And by and large, we'll be guiding people at least start with education. We've had many lectures, like Dr. Jibari have said, which are available on my YouTube channel, where you can easily go there and watch. And those of us that will want recorded version of the video, you can send me. I put my email address and my WhatsApp number there. You can send me a message. I can put it across to you. And I will also, on your behalf, implore our speaker to give out his slides so that doctors in their house that may want to go through it for more understanding can be able to have that privilege. So with all this, I want to say thank you very much. And if you are need for any other information, send me direct message. I can reply. So call it a day, yeah? It'll be a good day. Thank you very much, everyone. So
Good night, everyone.